were not at the right place because the lesion may be segmental and of different ages. In HSP, in general, you don't need a cutaneous biopsy to make the diagnosis, but if you have any doubts, you can do it, and you have a leukocytoclastic vasculitis, and you may have IgA deposition. And in GPA, you may have palisadic granuloma containing an arteriolar vasculitis. So, how to explore the vessels? For large and medium-sized vasculitis, of course, the imagery is very important. So you can use MRI or angio-MRI or angioscan, and they have an equal value for imaging the vessel lumen. But the angio-MRI is preferable because you minimize the exposure to radiation in children. And also, the angio-MRI is very interesting to see the arterial wall thickness, and you can see edema and late gadolinium enhancement. The Doppler is something interesting in children, and it's helpful to examine the carotid and the renal arteries. But of course, you cannot cover deeper arteries and usually not the whole aorta. But for follow-up, it can be really helpful. The PET-CT and the PET-MRI are very interesting for the detection of active large vessel vasculitis, if positive. But you have to keep in mind, but if it is negative at the beginning, it doesn't exclude a large vessel vasculitis, and you may have to repeat the exam in case. And also the digital subtraction arteriography. So we don't perform it a lot, but it's interesting when you want to analyze the smaller vessels, especially those inferior at 5 millimeters, including the coronaries, and if you are seeking for revascularization procedures. So what are my take-home message here? Think of systemic vasculitis when fever or unexplained inflammation, and examine the vessel systematically. Classification are useful, they are not the panacea. If possible, take a biopsy, especially in ANCA-associated vasculitis, and the muscular biopsy is in general have more rentability than the skin biopsy, even it's more simple. And it's not mandatory for HSP. The chest X-ray is mandatory in GPA, of course, and ultrasound for renal and carotid arteries may really be helpful in the follow-up. Evaluate all possible organ damage and do not forget the eyes and the nervous system. And in children, of course, think of genetic causes, especially if you have a very early onset, an atypical presentation, or a family history. So I thank you for your attention.
Thank you very much for a wonderful presentation. We do have some time for questions before we get into the main question session, if there's anyone who wants to ask any questions. Okay, there's something in the chat box, mononeuritis multiplex and non-systemic vasculitic neuropathy. What is different?
Mononeuritis, what is different?
Between mononeuritis multiplex and non-systematic vasculitic neuropathy.
This is a difficult question. What's different? Mononeuritis multiplex, you may have this in a systemic vasculitis. So I'm not sure I understand well the question. I'm sorry.
Well, that is what's in the chat box. So I'm not sure whether they trying to find out the difference between the neurologic involvement you get in systemic vasculitis compared to the other situation. I'm not sure.
No.
Any other questions? If not, then I'll call the session to a close. Oh, I see there's something here from, what exactly would you tell the surgeon how deep to go with the skin biopsy?
For the skin biopsies, they need to go to a recent lesion. This is quite better because it's an old lesion. They cannot find a lot of information here. And preferably, it's deep biopsy. So you have to be in the derma at the minimum. But I think that the best rentability if when you do a muscle biopsy, because you have more chance to have a vessel and to see quite better.
Thank you very much. I see there's a comment that says it was an excellent topic and presentation.
Thank you very much.
Okay, so I think I'm going to close the session now, and maybe we can go on to the next speaker. Let me just see, there's another question that came in. In polyarthritis nodosa, according to your experience, what is the best maintenance therapy between methotrexate and MMF?
For our recommendations, it is the same. There is no differences among methotrexate and MMF, but in our department, I have to say that we use better MMF or azathioprine, but methotrexate is also falls into our recommendations.
Thank you very much.
Over to you, Professor Lebouguet.
I say another question. I don't know if I have to answer it about colchicine vasculitis. So we use colchicine sometimes in enotonite purpura where we have persistent skin rash that may be necrotic, and sometimes it's not aesthetic, and also it can be anxious. The patient is anxious. And in this case, we can use colchicine and it may be effective in this case. And also, if it is associated with FMF.
Thank you very much.
Over to you, Professor Piero.
Can I hand over to Professor Piero Lebouguet?
Yes. Good morning, everyone, and good afternoon. It's a great pleasure to participate in this great Congress of Pediatric Rheumatology in Africa in this session concerning vasculitis and autoinflammatory disease. I'm an adjunct pediatric rheumatology performing at University Hospital of Kinshasa in Democratic Republic of Congo. It's a pleasure to introduce today this presentation of the new recommendations for diagnosis and treatment of Kawasaki disease. This presentation will be made by Professor Kenza.
Hello.
Hello?
Oh, hello, Kenza. I think probably there's a technical issue.
Okay.
Yeah, I'm just.
You want me to start?
What?
Ivan's asked me to start.
Yes, I think you can start. That's what I want to tell you. Thank you.
Okay. Just a few minutes. Bonjour, chers collègues. Je suis extrêmement honorée de pouvoir participer à cette seconde édition du Congrès africain de rhumatologie pédiatrique. Et je remercie les participants de m'avoir confié la tâche de parler de cette maladie de Kawasaki. Alors. J'ai un petit problème. Je n'arrive pas à passer en mode plein écran. Is it in full screen, please? Sorry. Is it in full screen, please?
No, no, it's not.
No.
I don't know. There is a problem. I cannot. And I need to put in full screen.
You can see there's a play button up there.
Sorry? Yes, I know, but I don't have the possibility to do it.
Okay, you can just stop sharing your screen and then reshare.
Okay. Sorry. I have a problem.
Okay.
I can ask. Yes, it's okay. J'ai toujours ce problème. I can't share in the full screen. How can I do, please? I have a problem. It worked before, but now.
When you click on the play button on top, does it
I will continue. I'm sorry. I have a problem, but I don't know how to do.
you can just proceed?
Je pense que le problème est peut-être dans, tu peux peut-être le résoudre dans la barre du haut. Je pense que c'est le mode de présentation qui affiche
Oui,
les.
mais je sais, mais je n'arrive pas. J'ai pas la main pour
Ah,
mettre
t'as pas la main. Ah, ouais.
Oui, alors je ne sais pas ce qui se passe. Voilà, je regarde toute la barre du haut, désactiver, vidéo, participants, discuter, mais je n'ai pas le full screen. Je ne sais pas ce qui se passe. Ça a marché tout à l'heure et je suis embêtée. Bon, ben, je vais continuer. I will continue. I'm really sorry. I don't know what happened. Alors, la maladie de Kawasaki est la vascularite pédiatrique par excellence. Elle se situe en seconde position après la vascularite du purpura rhumatoïde. Son diagnostic repose sur des critères cliniques et il s'agit de la première cause de cardiopathie acquise dans les pays développés et la seconde cause dans les pays en voie de développement. Donc, cette maladie de Kawasaki, en fait, fait partie intégrante des vascularites primitives. Et cette photo illustre en fait la classification de Chapelil qui a été déjà projetée par Isabelle et où l'on voit que la maladie de Kawasaki touche les vaisseaux de moyen calibre avec la périartérite noueuse. Cette maladie de Kawasaki a longtemps suscité beaucoup d'intérêt et continue à susciter beaucoup d'intérêt parmi les scientifiques, comme en témoigne cette pléthore de publications. Et donc là, ce sont les dernières publications concernant uniquement les recommandations. Et on peut voir là qu'en 2022, en avril 2022, de nouvelles recommandations ont été publiées. Ces nouvelles recommandations donc, ont été faites par l'American College of Rheumatology et le Vasculitis Foundation, et elles arrivent un petit peu comme un supplément additionnel pour conforter les recommandations qui existent déjà en matière donc de Kawasaki par l'American Heart Association et la Chair Initiative qui sont des recommandations européennes. Donc vous voyez qu'il y a des publications également en matière de traitement, et en particulier traitement par corticoïdes. Et on sait combien les corticoïdes ont été délaissés dans la maladie de Kawasaki pendant plusieurs années. Et là, elles connaissent un regain d'intérêt et on comprend bien le pourquoi de la chose. On sait que le Kawasaki est une vascularite primitive et que pourquoi pas les corticoïdes comme dans les autres vascularites. Alors, beaucoup de publications aussi en matière donc, de traitement par l'aspirine, quelle dose, les immunoglobulines, pareil, quelle dose. Donc, je vais commencer par le commencement et donc par le diagnostic. Et le diagnostic est établi sur des critères cliniques qui ont été élaborés par l'American Heart Association et publiés une première fois en 2004, puis révisés en 2017. Et donc, ces critères sont au nombre de 6, avec la fièvre comme un critère qui est obligatoire pour retenir le diagnostic de maladie de Kawasaki. Cette fièvre doit impérativement avoir une durée minimum de 5 jours, associée à d'autres signes, et notamment la conjonctivite bilatérale non purulente, l'adénopathie cervicale, comme ça a été montré par Madame Conepo précédemment, qui est en fait une adénopathie plus souvent unilatérale, qui est plutôt volumineuse et qui dépasse en général 1,5 cm. L'éruption cutanée qui est polymorphe et en fait qui n'a aucune spécificité, la kéylite et puis l'atteinte des extrémités avec 2 phases. Une première phase inflammatoire et une seconde phase subaiguë qui est en général desquamative. Et pour retenir le diagnostic de maladie de Kawasaki de manière formelle, donc il faut 5 critères parmi les 6 cités, sachant que la fièvre est obligatoire. En 2017, la révision a porté essentiellement sur la durée de cette fièvre. Et aujourd'hui, on est capable de retenir une maladie de Kawasaki en présence de 5 critères sur 6, même si la fièvre n'a pas encore atteint les 5 jours. Et là, ce sont quelques images de patients que je voudrais partager avec vous. Donc là, c'est un petit garçon qui est atteint de maladie de Kawasaki. On voit bien l'injection oculaire bilatérale. On peut deviner également les lésions cutanées qui sont maculo-papuleuses, érythémateuses et qui touchent ici exclusivement le visage. La kéylite, comme vous pouvez le voir. Chez cette petite fille, on est frappé par l'aspect très inflammatoire, rouge et tuméfié des lèvres. Et chez ce petit nourrisson, on peut voir l'atteinte des extrémités en phase inflammatoire, comme vous pouvez le constater, qui sont gonflées, qui sont rouges, et également un rash cutané en regard des genoux. Donc là, on peut constater donc, ce rash qui est morbilliforme au niveau du tronc, et puis ces atteintes des extrémités en phase inflammatoire au niveau du pied, au niveau de la main. Et là, c'est plutôt la phase subaiguë dont on a parlé, qui est une phase desquamative, avec des squames larges en lambeaux et qui démarrent en général au niveau des pulpes. Donc, toutes les situations ne sont pas aussi simples que ce qu'on a pu voir ici. C'est-à-dire que certains malades ne remplissent pas l'ensemble des critères, ce sont ces formes incomplètes. Et c'est là que se pose le problème diagnostique. Et finalement, chaque fois qu'on est en situation d'un enfant, d'un nourrisson qui présente une fièvre qui dépasse 5 jours, qui est soit isolé et qui reste sans explication, ou avec quelques-uns des symptômes, eh bien, la première chose à faire, c'est de confirmer qu'on est bien dans un contexte inflammatoire. Et donc, on va demander une C-réactive protéine et une vitesse de sédimentation à la recherche de ce syndrome inflammatoire. Très bien. Une fois qu'on a confirmé le contexte inflammatoire, on peut s'aider d'autres outils, à savoir demander une simple numération à la recherche d'une anémie, à la recherche d'une hyperplaquétose au-delà de 450 000, d'une thrombopénie en deçà de 140 000, à la recherche d'une hyperleucocytose au-dessus de 15 000. On peut s'aider également d'un dosage de l'albumine à la recherche d'une albuminémie, d'un taux de transaminase à la recherche d'une augmentation du taux d'alate et d'un ECBU à la recherche d'une leucocyturie. Bien évidemment, à chaque fois qu'on est dans une situation d'enfant ayant une fièvre dépassant les 5 jours dans un contexte inflammatoire, et de surcroît, si vous avez une éruption cutanée, on pense à la maladie de Kawasaki et on va demander systématiquement une échocardiographie. Quand nous avons des atteintes coronaires, le diagnostic, bien sûr, est confirmé d'emblée. Dans le cas contraire, on va aller piocher sur les bilans dont je viens de parler et donc on exige 3 parmi les bilans biologiques pour confirmer le diagnostic de maladie de Kawasaki. Et là, je voudrais donc partager avec vous un cas de maladie de Kawasaki incomplète. Il s'agit d'un petit nourrisson de sexe féminin qui a été admis en octobre dernier à l'âge de 5 mois pour une fièvre dépassant 7 jours avec une kéylite, une conjonctivite, une atteinte des extrémités. Donc, cet enfant totalisait 4 critères sur 6. Nous avons confirmé le contexte inflammatoire par la réalisation d'une vitesse sédimentation qui était élevée à 120 mm à la première heure et une CRP qui était augmentée à 207 mg par litre. Nous avions également une anémie à 9,1 g par décilitre, hypochrome microcytaire, une hyperleucocytose franche et une thrombocytose avoisinant les 700 000, ce qui nous a permis de retenir le diagnostic de maladie de Kawasaki sans atteinte coronaire. Ce petit nourrisson a été traité classiquement par des immunoglobulines, de la prednisone et de l'aspirine. Et l'évolution a été marquée par une apyrexie très rapide avec une évolution très favorable et disparition de tous les symptômes cliniques, avec, comme vous pouvez le constater, cet œdème de la phase inflammatoire qui a disparu et qui a été remplacé par de la desquamation en lambeaux qui démarrait au niveau des pulpes de doigts. Pardon. Alors, à la lumière, hop. À la lumière de cette observation, donc nous allons parler du traitement de première ligne, qui lui est un traitement complètement codifié et qui fait complètement l'unanimité. Et en fait, il repose sur les immunoglobulines intraveineuses à la dose de 2 grammes kilo, sur un traitement par aspirine à des doses dites moyennes de 30 à 50 mg kilo par jour, et par opposition à des doses plus élevées de 80 à 100 mg kilo jour, qui étaient longtemps prescrites par les Américains. Et en fait, cette recommandation vient à la lumière d'un travail de méta-analyse publié en 2020 sur rhumatologie, et où les auteurs ont recherché tous les articles étant parus avant 2019 et qui contenaient des maladies de Kawasaki traitées par aspirine, quelle qu'en soit la dose. Et en fait, ils ont retenu finalement 8 articles qui totalisaient quand même 12 000 patients Kawasaki. Et les auteurs concluent que, quelle que soit la dose d'aspirine, qu'elle soit modérée ou qu'elle soit élevée, l'impact sur les coronaires est identique, avec par contre un bénéfice très évident en matière de tolérance. Cette dose va être maintenue jusqu'à, bien sûr, obtention de la pyrexie, et ensuite, on va passer à une dose antiagrégante plaquettaire de 3 à 5 mg kilo jour, qui va être maintenue jusqu'à normalisation des marqueurs inflammatoires. En cas d'atteinte cardiaque, cette dose va être maintenue jusqu'à un retour des images échocardiographiques à la normale. Donc, vous avez vu que notre patiente a été traitée par corticothérapie. Oui, en effet, les corticoïdes sont fortement recommandés chez les nourrissons de moins de 12 mois, pour la simple raison que ces nourrissons vont faire des formes très inflammatoires de maladie de Kawasaki. Ils font beaucoup de formes incomplètes, ce qui va occasionner un retard dans le diagnostic, et ils sont vraiment l'apanage d'anévrismes coronaires. Donc, pour les patients qui ne répondent pas au traitement de première intention, on va parler de formes résistantes. Et si on devait définir ces formes résistantes, ce sont des formes chez qui la fièvre va persister après 48 heures de l'administration de la première perfusion d'immunoglobulines, ou alors peut-être disparaître pour réapparaître très vite et persister. Elles représentent quand même 10 à 20% de l'ensemble des patients traités pour maladie de Kawasaki. Elles vont être traitées par un traitement dit de seconde ligne qui repose sur une deuxième perfusion d'immunoglobulines avec ou sans corticoïdes. Et là, c'est vraiment à la discrétion du clinicien. Ce sont des formes qui sont très à risque de développer un anévrisme coronaire. Et c'est dommage que je ne puisse pas animer, mais là, c'est un petit garçon âgé de 2 ans et 8 mois qui est hospitalisé actuellement chez nous et qui a été admis en juillet de l'année dernière pour une forme de Kawasaki complète. Il a été admis à J15 de vie. Et à J16 de vie, c'est-à-dire le lendemain, il avait bénéficié d'un traitement de première intention et d'une première échographie qui était normale. À J20 de vie, il a été étiqueté forme résistante de maladie de Kawasaki devant la persistance de la fièvre. Nous avions indiqué une seconde perfusion d'immunoglobuline. Malheureusement, ce n'était pas valable, ce n'était pas disponible au service. On a pu réaliser une seconde échocardiographie à J9 d'hospitalisation et cette échographie a révélé un double anévrisme de l'artère coronaire gauche ainsi que de l'artère coronaire droite avec un thrombus et une dilatation de l'artère interventriculaire antérieure. Donc, devant cette atteinte cardiaque sévère, cet état de fièvre persistante, de syndrome inflammatoire et en l'absence d'immunoglobuline, le patient a été traité par 3 bolus de méthylpred à la dose de 30 mg kg jour et par anticoagulation. Nous avons pu réaliser une écho-cœur à 1 semaine donc, de ce traitement qui montrait le même aspect échocardiographique avec tout de même une régression de l'anévrisme. Donc, le patient est sorti sous anticoagulation et petite dose de corticoïdes et il a été perdu de vue entre le mois d'août 2021 et le mois de mars 2022. Et là, il arrive avec vraiment une aggravation de son atteinte cardiaque, comme vous pouvez le voir. Et devant cette aggravation, même en l'absence de syndrome inflammatoire, nous avons décidé d'intensifier le traitement par 3 bolus de méthylpred et de l'anakinra pendant 2 mois. Et vu l'absence d'effet sur les écho-itératives, nous avons stoppé donc tout traitement anti-inflammatoire et maintenu uniquement le traitement anticoagulant. En juin 2022, c'est-à-dire la dernière échographie, nous assistons encore à une aggravation de l'atteinte cardiaque avec apparition d'un nouveau thrombus. Et là, nous avons présenté ce patient aux chirurgiens cardiovasculaires qui ont indiqué un traitement chirurgical parce que cet enfant a un risque de rupture d'anévrisme qui le guette à tout moment avec risque de mort subite. Donc vraiment, c'est une histoire extrêmement malheureuse et c'est pourquoi il est intéressant de travailler avec des scores prédictifs de forme résistante afin peut-être de pouvoir initier des traitements très agressifs très précocement et peut-être éviter ce genre d'évolution extrêmement sévère. Les scores qui existent aujourd'hui, ce sont des scores qui ont été tous établis par des équipes japonaises sur des patients japonais. Alors, le Kobayashi score, les GAMI, le Sano et d'autres. Ils ont été également testés sur des populations américaines et canadiennes avec une très faible sensibilité, sauf le Kobayashi qui, lui, a par contre été testé sur des patients atteints de Kawasaki d'origine allemande et britannique avec une très bonne sensibilité. Et donc, ce score de Kobayashi, en fait, comprend 7 paramètres ou 7 variables et chacune des variables va être cotée par un système de points. Et quand le patient atteint 4 points, on estime que c'est un patient qui est à haut risque de résistance. Donc, ces patients résistants sont à haut risque également d'atteinte cardiaque. Et l'atteinte cardiaque a une incidence qui est estimée à 25% chez les patients non traités. Elle va baisser à 5% grâce à l'utilisation des immunoglobulines intraveineuses. L'atteinte classique, alors, il faut savoir que la maladie de Kawasaki peut toucher toutes les tuniques cardiaques. Mais l'atteinte classique, c'est l'atteinte coronaire, qui peut apparaître sous forme de dilatation, d'anévrisme, mais aussi de complications, comme on a pu voir, de thrombose, d'obstruction ou encore de rupture d'anévrisme. Et pour évaluer la sévérité de cette atteinte coronaire, il va falloir donc aller vers des échographies qui vont mesurer la taille de l'anévrisme. Ce qui est essentiel, c'est que cette échographie doit être impérativement réalisée par un senior cardiologue pédiatre qui est très entraîné et qui a une véritable expertise en matière de cardiologie pédiatrique. Donc, comment finalement surveiller ces patients ayant une maladie de Kawasaki? Alors, il y a la surveillance biologique qui va se faire essentiellement par la C-réactive protéine. Oubliez la vitesse sédimentation en matière de surveillance parce que tout simplement, elle est impactée par les doses d'immunoglobulines. Et puis, il va y avoir l'imagerie. L'imagerie, c'est l'échocardiographie. Alors, nous avons deux cas de figure. Le premier cas de figure, c'est le cas où les patients n'ont pas d'anévrisme coronaire. Et là, il y a 3 échos. Une première, au moment où vous portez le diagnostic de maladie de Kawasaki. La seconde, 2 semaines après l'administration des immunoglobulines, parce que parfois on passe à côté d'une atteinte cardiaque, comme ça a été le cas chez notre patient. Et la dernière, 6 à 8 semaines après le début de l'installation de la maladie, pour s'assurer de l'intégrité du système coronaire. Enfin, il y a la seconde situation où l'atteinte coronaire existe, et là, on va avoir une surveillance beaucoup plus rapprochée avec une rythmicité hebdomadaire d'échographie, et ce jusqu'à normalisation ou stabilisation des lésions coronaires. Donc, après la surveillance, on va continuer sur le traitement, et là, donc, je voulais parler de ce qu'il y a de nouveau en matière de prise en charge thérapeutique. Eh bien, ces corticoïdes qui ont longtemps été bannis de l'arsenal thérapeutique de la maladie de Kawasaki, aujourd'hui, c'est très simple, ils reviennent en force avec des indications bien précises, à savoir des formes résistantes, des formes ayant des traits cliniques, des traits biologiques d'activation macrophagique, ou des signes cliniques d'état de choc, et c'est ce qu'on appelle le Kawasaki Shock Syndrome. Chez ces jeunes nourrissons de moins de 12 mois, on a bien expliqué le pourquoi, c'est parce que c'est des formes très inflammatoires avec risque élevé d'anévrisme coronaire. Chez les patients ayant des anévrismes et chez les patients ayant un Kobayashi score au-delà de 4. Alors, si les indications des corticoïdes sont bien connues et font consensus aujourd'hui, la dose optimale, la durée de traitement et la date d'initiation des corticoïdes restent toujours un vrai sujet à controverse. Et il y a 2 schémas thérapeutiques qui sont proposés. Un premier schéma où on démarrait avec des petites doses en intraveineux et on prendrait un relais par voie orale, ou encore d'emblée par voie orale pour un traitement de 3 semaines au total. Et puis un autre schéma où on est un peu plus agressif et où on mettrait des fortes doses de méthylpred à la dose de 30 mg kg/jour, 3 jours de suite, et puis on relayerait par la prédnisone par voie orale. Seulement, il y a des situations où ces traitements, aussi bien de première intention que de seconde intention avec corticoïdes, ne marchent pas et que le patient continue à être fébrile, continue à avoir un syndrome inflammatoire et présente des anévrismes coronariens. Et là, que faire? Et là, donc, on va parler du traitement de 3e ligne. Alors, le traitement de 3e ligne, on va parler des biologiques. Et pourquoi les biologiques? Les biologiques, c'est-à-dire ce sont des agents qui vont cibler les cytokines inflammatoires. Et on sait que la maladie de Kawasaki est une maladie qui est excessivement inflammatoire, qui met en jeu l'immunité innée et qui active des cascades cytokiniques. Donc, pourquoi pas agir directement sur ces cytokines? Et je commencerai par l'anakinra. Alors, l'anakinra est un anti-interleukine 1. Et je partage avec vous cette publication faite en 2020 et qui regroupe l'ensemble des patients qui ont été traités par anakinra pour une maladie de Kawasaki compliquée d'anévrisme coronaire. Et là, cela totalise 38 patients, dont 22 sont des cas individuels et 16 cas, ce sont des cas appartenant à une même série française, Kawakinra. D'ailleurs, c'est une série qui a été publiée par Isabelle Conepo. Et donc, cette série montre une excellente évolution sur le plan clinique et biologique, avec en plus une excellente tolérance chez les patients. Et les auteurs concluent que l'anakinra constituerait une excellente alternative après l'échec d'une première perfusion d'immunoglobulines, essentiellement quand vous avez une atteinte coronaire associée. Deuxième traitement biothérapie, c'est l'infliximab. Et l'infliximab est un anticorps monoclonal anti-TNF-alpha. Et déjà en 2008, les premières études japonaises montraient que dans les sérums des patients atteints de Kawasaki, les taux TNF-alpha étaient très élevés. Alors, beaucoup de patients ont été traités par infliximab, mais vraiment, ce sont des cas faits de manière tout à fait individuelle. Et j'ai trouvé cette petite étude de 11 cas de malades traités par infliximab après une résistance aux immunoglobulines. Et on voit chez ces patients que la réponse clinique est excellente, que les marqueurs d'inflammation ont pu être diminués de manière significative. En revanche, il persistait une augmentation des marqueurs de vascularite. Et finalement, les recommandations de la chaire initiative conseillent de donner de l'infliximab après échec de 2 doses d'immunoglobuline associées à une corticothérapie. Qu'en est-il de l'étanercept? Expérience très limitée, aucune recommandation. Quant au tocilizumab, donc, pareil, la littérature est très pauvre et j'ai pu trouver uniquement cette petite étude pilote portant sur 4 patients. Et ce sont des patients qui, initialement, n'avaient pas d'anévrisme coronaire. Et après la perfusion de tocilizumab, 2 de ces patients ont développé un anévrisme coronaire. Et ici, les auteurs suggèrent que le tocilizumab a pu accélérer la formation d'anévrisme. Donc, il n'a aucune place en matière de maladie de Kawasaki. Et enfin, pour conclure, je dirais que le diagnostic de maladie de Kawasaki n'est finalement pas si simple comme on a pu le voir, mais heureusement, nous avons cet algorithme de l'AHA qui nous permet, et qui est un excellent outil pour orienter le clinicien et l'aider à faire son diagnostic. Qu'en matière de consensus, seul le traitement de première intention est consensuel et bien codifié. Par contre, concernant ces formes réfractaires avec ou sans anévrisme coronarien, le choix thérapeutique idéal n'existe pas et c'est vraiment un sujet qui reste complètement en controverse. Alors, quelque chose d'important aussi, c'est les cas de patients atteints donc de maladie de Kawasaki ayant fait une atteinte coronaire. Et donc, même quand l'atteinte coronaire régresse, bien évidemment, le pronostic à l'âge adulte reste complètement incertain et le mieux, ce serait d'avoir des études prospectives ou alors en tout cas d'avoir des cohortes d'adultes ayant un Kawasaki disease dans la jeunesse et donc pouvoir aller les explorer sur le plan cardiaque. Et pour finir, je dirais que sur le continent africain, où les conditions locales sont assez différentes et disparates, il faudrait peut-être adapter le traitement et essayer d'être le plus proche possible des guidelines internationaux. Et s'il n'y a pas d'immunoglobuline, je serais pour dire qu'il est complètement légitime de prescrire des corticoïdes qui aujourd'hui ont été complètement réhabilités dans cette maladie. Et je vous remercie de Casablanca. Un grand merci.
Thank you very much for an interesting presentation. I'm afraid that we don't have time for questions, but there will be a few minutes allocated at the end of the talk. So we're now going on to the next session, which is going to be by Dr. Francis Furia. Dr. Francis Furia is a clinician at Muhimbili National Hospital and an associate professor of Muhimbili University and Health Sciences. He runs a pediatric nephrology and rheumatology service at the Muhimbili National Hospital. He's published several articles in peer-reviewed journals, and his research interests include nephrology, rheumatology, general pediatrics, health services, and child health. Dr. Furia holds fellowships from various institutions, including International Society of Nephrology, International Pediatric Nephrology Association, and the Royal College of Physicians of London. It's indeed a pleasure to introduce to you Dr. Francis Furia, who's going to talk to us about Takayasu arthritis, when to think about it, and how to manage. Thank you.
Thank you, Professor Kala, for those kind words. And my talk is going to be on Takayasu arthritis, and I'm happy that the previous speaker, particularly Professor Isabella, is alluded to most of the things that I might be talking about. So my talk is basically on when to think of Takayasu arthritis and how to manage it. I have nothing to disclose except, of course, that I'm not an expert in Takayasu arthritis by no means, but I will share the little experience that I have. On the picture is the hospital that I work at, and it's the largest hospital in Tanzania. It's the national hospital, and we have a bed capacity of around 200, and it's both medical and surgical conditions that we see. So my talk is supposed to be on Takayasu arteritis, and Professor Isabella has definitely talked about this, that Takayasu arteritis is chronic idiopathic granulomatous vasculitis, which is involving the aorta and its main branches, resulting in stenosis, occlusion, and sometimes you can also get aneurysm. And based on Chapel Hill classification, this is classified as a large vessel vasculitis. Of course, there's missing data on epidemiology of this condition, particularly in children. And annual incidence in southern Sweden, it was estimated to be 0.04 per million, and the prevalence reported in Korea was between 0.04 to 0.03 per 1,000 children. And this was a retrospective study that was done for almost 4 years, and the prevalence went up as the age increased. And the peak age is around 12 years for children with Takayasu arteritis. So this is a common condition, and previously people might thought that it might not be affecting African children, and partly because we are really rarely diagnosing it. And I think I can from studies that have been published largely in South Africa, they are showing that we have this condition. It's quite common. Although it's not very, very common, but it is picked up. So in this study, which was published by Celia et al., which is looking at, which was data collected in Krishan Baragwanath's hospital. I mean, there were 55 children that were noted in a period of 1993 to 2015. So you could see, I mean, these kids could be picked up, and the mean age was around 9 years. Of course, another study that was done in South Africa, again by Han et al., it showed that the children with children Takayasu arteritis can be picked up, and of course, the age was between 2.22 to almost 15 years. And it was affecting children of all races. Of course, majority of them were African origin, so as 80%, but these other ones were also noted. And when it comes to the type of vessels that were really involved, because it's a disease that is affecting the aorta and its main branches, you could see there's 5 types, so which are shown on the left side of the screen. So you could definitely see the types that were described. So almost 36% had type 2 and type 3 each, and the least common was type 4. We also have documented Takayasu arteritis in Tanzania in a retrospective review that we did from a period of 2012 to 2019. So 2 children were picked to have Takayasu arteritis. So it is not something that we don't see. So Takayasu arteritis has 2 phases. It has pre-occlusive phase, which is also known as systemic phase. And at this time, this is generally presenting with non-specific manifestation. And unfortunately, these manifestations are the ones that are usually mistaken to be infections. These will be fever, malaise, weight loss. And these are the kind of clinical features that whenever patients are presenting to us, they will be thought of having infectious condition. And it is usually unnoticed. It's hardly noticed, and most of the time it is identified retrospectively if you ask about it. And it could run for months to years at times. And the second phase is the vascular phase, and this vascular phase is the one which is diagnostic. Most of the time when patients are diagnosed with Takayasu arteritis, they are presenting at this particular stage, and they have arterial lesions that could present with stenosis, obliteration, aneurysm, and complications of these conditions. And these are the on the right side, you could see the type of vessels that are usually affected and the frequency. And you could see the commonly affected vessels are the renal arteries. and of course followed by the carotid arteries, but several others can be affected. And so it shows that when these patients present to the hospital, they could present with renal manifestation, and that could be the first time that they are coming to the hospital. So the clinical features, as we saw previously, hypertension is quite common. More than 70% of children that have Takayasu arteritis will present with hypertension, but also with other complications of hypertension, including hypertensive crisis, heart failure, and other complications that comes with that. They could present with dyspnea, which could be a complication of heart failure as well. And they could have fever, headache, and weight loss, as I alluded to before. But also they could present with specific organ-specific features, and these include the discrepancies in blood pressure between the two arms, and also you might have decreased pulse, as well as bruit of large arteries. And you could see the frequency with which these manifestations are. With hypertension, more than 70%, 60% will present with BP discrepancies, and then you have almost 60% having decreased pulses. And they could also, as I said, cardiomyopathy and stroke, and as well as seizure is manifestation. So before I go on, I would like to share with you the first patient that came to us with Takayasu arteritis. So this, he was 17 years old, who presented. He was a high schooler, referred to us because of high blood pressure, which was severe, which was not controlled. And on the first visit, I did see him, and he had elevated blood pressure. I examined him. The only thing that I examined was his right radial pulse and his blood pressure. And I also examined his precordium, and the apex beat was in the 5th intercostal space, mid-clavicular line. And of course, I requested serum creatinine urinalysis and ultrasound, ECG, and echo, just to evaluate what could be the possible manifest complication of this condition. And he came on the second visit after doing this initial test. That was 2 weeks later. And a colleague of mine, we're sitting in the same room, and a colleague of mine told me that, you know, we have this patient who was seen 2 weeks ago and did some tests, but nothing was noted to be remarkable. Urinalysis was okay, creatinine was okay, and KOB ultrasound was also normal. ECG and echo just showed features of left ventricular hypertrophy. And when they asked me, I told him, can you please examine all the peripheral pulses? And he told me that several of the pulses were missing. So at that particular time, the diagnosis clicked on my mind that possibly we are dealing with Takayasu arteritis. And of course, it turned out that this patient was diagnosed to have hypertension 1 year earlier before coming to us. And this was diagnosed when he was getting ORIF removed, because he had tibial fracture, open tibial fracture, which required ORIF, and he was given antihypertensive for that matter. And we did CT autogram, which showed the features consistent with Takayasu arteritis, and we had the diagnosis of Takayasu arteritis. So this shows how easy it is to miss this condition. So if you're looking at this condition, so there are several challenges that are facing us to diagnose Takayasu arteritis. Of course, we know that hypertension is the most common presentation of Takayasu arteritis. And it is defined in a very complicated way, basically, because if you are looking at the children, if you really want to define hypertension, you have to look at their blood pressure, look at their age, and look at their height. And as you all know, that children comes in different shapes and sizes and ages. And if you really want to check their blood pressure, you have to get different cuff sizes and make sure that you get them relaxed and to check your blood pressure. And your hypertension will be defined as when blood pressure is above 95th percentile, but 90th to 95th percentile, that is elevated blood pressure, which is definitely not normal. So the implications of these criteria for defining hypertension makes it difficult and sometimes challenging. Most of the facilities that are caring for children, particularly in sub-Saharan Africa, except for the big referral facilities and tertiary hospitals that patients present. So in one of the studies that were done in sub-Saharan Africa, meta-analysis, which was looking at the hypertension in children, there were data from 10 sub-Saharan African countries with 52, with almost 52,000 children included, age ranging 3 to 19 years. And these studies was conducted, the studies that were included in these studies were those that were included between 2017 and November 2000. And the pool prevalence of hypertension was 7.45%, so almost 7.5%. And if you look at the combined blood pressure and elevated blood pressure and hypertension, you get a prevalence of 21%, which shows that hypertension is quite common. So, and one we wonder, we know that hypertension most of the time in children is secondary. So is it possible that some of these children that presented with hypertension could have presented with Takayasu arteritis as one of the causes? So as I said, hypertension can be difficult to diagnose. And this is a typical example, a study that was done in Ohio Health System between June 1999 and 2006. They were looking at all children that presented with at least three visits documented with e-records who were presenting to well child care. And out of these children, elevated blood pressure and hypertension was noted in 3.6% of those children, and which is 14,000 children. And of all these, only 126 children, which is 26%, had the diagnosis of hypertension included in their records. That means more than 75% of children that had hypertension were missed, and this is Ohio. So you could really see what is happening in our setting as far as hypertension is concerned. So in this study, which was done by Han et al., which was looking at the children that presented with Takayasu arteritis, you can see that the most common features that were noted were hypertension, bruit, and absence of pulses. And so basically, looking at this presentation, I could definitely say that the most important tool for picking Takayasu arteritis will be our fingers, basically. So if you get any child that is coming to you with hypertension, if you run your fingers through the pulses, you might be able to diagnose most of these children with Takayasu arteritis. So these are the criteria for diagnosing Takayasu arteritis, as Professor Isabella has talked about, that you need angiographic abnormalities and at least one of the following features, which include pulse deficit and bruit, hypertension, and elevated acute phase reactants. So basically, my take is the fact that for you to be able to diagnose this condition, you need to start with hypertension, and the next thing is look for the pulse, particularly when in our setting. Of course, acute phase reactants are important markers that have been identified that should be looked for, which are aiding the diagnosis. Unfortunately, they are very non-specific, and if they are increased, that can confirm that there is inflammation. But if they are not increased, there's no way you can say that there is no active disease. So there are reports that you could have an active disease, but the markers will not be elevated. And of course, the other commonly markers that are presenting with this in pediatrics that we're using for diagnosing of this condition is ESR and CRP. Of course, it goes without saying that sometimes you might have anemia and thrombosis in these children when they are presenting to us. So one of the another backbone tool for diagnosing this condition, as we said, is the angiographic findings. And of course, you need to document these. And so that means arterial imaging and imaging of the aorta and its branches plays a big role in making sure that we diagnose this condition. And we are looking at the morphological impairment. And of course, you can also detect inflammatory activities in the vessel walls. And there are three modalities that are of choice. It is, you could use an ultrasound, which is very easy and cheap and no radiation. You have angio-CT and angio-MRI, as well as PET scan. The ultrasound is very handy and it is cheaper, friendly, and you can determine hypoechoic perivascular halo, and the only challenge is the fact that it has limited access because you can only do the test on those vessels that are accessible to ultrasound, which include the carotid and axillary, abdominal aorta, of course, and the renal vessels. And occasionally you might be able to do transcranial Doppler and get some of these things. And IETs also need to appreciate that it is operator dependent. So sometimes you might miss things depending on who's getting your scan done. And this is just an example of the ultrasound scan, which is showing you that the wide thickening of the vessel wall, which can be clearly appreciated. And so as we know that plays an important role, imaging is backbone of the diagnosis. It can pick, so particularly the CT angio and MRI can pick the arterial stenosis and aneurysm. Angio CT has excellent isotopic resolution, you know, and it can, you might be able to detect aortitis, which is characterized by circumferential parietal thickening. But again, there's an issue that it has radiation exposure, which makes it quite limited in children, particularly if you really need to do it several times. Angio MRI is quite good. It has an advantage of no radiation exposure. And it can also pick signs of vascular inflammation, particularly when you are using T1 weighted imaging. Another imaging is PET scan, which we've seen the images that were shown by Professor Isabel, showing the degree, which shows the degree of inflammation by consumption or uptake of radioactive glucose in the infiltrate in the arterial walls. So this is just an example of a case that was presenting with Takayasu arteritis, and on the right side you can see clearing of the signals for the indicating that there is no increased uptake anymore as before the when the disease was active. So this is a table which is showing us the role that can be played by each of these imaging technique. And you can see that stenosis can easily be picked up by arteriography, Doppler, angio, and angio MRI as well. And you can see that if you're looking for the vascular wall inflammation, then your Doppler ultrasound can show a bit of that, and your CT scan can also show that. But PET scan is the best if you're looking at that. And if you really want to pick the flow, then it's your Doppler ultrasound as well as angio MRI. So this is just showing how useful this imaging can be when you are confronted with these children. So when it comes to treatment of Takayasu arteritis, this is something that we've been struggling with for a long time. And the challenges are, can you really tell that this is progressive or a relapsing type of disease? And we always have diagnostic delay because, and by the time these patients are diagnosed, you have irreversible vascular damage and secondary organ damage. And we don't have biomarkers to detect the disease activity. And the mainstay of treatment has been corticosteroids, and some people might start with methylprednisolone, 15 milligram per kilogram for 3 days, particularly when they have severe and life-threatening disease, and followed by oral steroids. And of course, using these steroids for a long time is difficult. So initial therapy of steroid will be 2 to 4 weeks. After that, you might need to taper down your dose of steroids and use corticosteroid-sparing agents in the form of methotrexate, which is commonly used and readily available in most of the setting, azathioprine, as well as MMF and cyclophosphamide. Cyclophosphamide has been used for extensive and life-threatening disease, and it's one of the molecules that was heavily used before we had access to the new molecules that are available. Of course, with the increased understanding of the disease pathophysiology, cytokines, including interleukin 6, 18, and tumor necrotic factor, the use of biological therapy has been tried and has shown success in most of the time. The only challenge that we have is the fact that most of the studies that are indicating the use of biologics are all retrospective studies and small studies. So we don't have strong evidence to guide the treatment of Takayasu arteritis using biologics. This is an example of some of the studies that have shown that biologics can be useful in this. And this is a study which was published in Toronto, sick kids. And so you can see that with the use of biologics, which is indicated by the use of rates, and the biologics that were used were infliximab and tocilizumab. And these were shown that you could have 2-year flare-free survival was 80% in those who used biologics as compared to 43% in those that were not using biologics. And so that there's a promise with these biologics as one of the important treatment options for these children. So it is also important to remember that when you are confronted with these children, it is important to use vascular protection therapy in the terms of management of hypertension. They usually present with hypertension. ACE inhibitors and angiotensin receptor blockers, if they are combined with calcium channel blockers and thiazide diuretics, are quite useful, but you need to make sure that you don't have bilateral renal artery stenosis before you use AC and ARB indicators. In some cases, you might need to use platelets anti-aggregants in the form of aspirin. And if you have severe form and you're worried, you might also consider using statins. And of course, there's room of vascular interventions in the form of surgery. And this is endovascular as well as vascular surgery, particularly for symptomatic organ ischemia, life-threatening conditions. And the main indication in children, main indication for children for surgery is renal artery stenosis. And option transluminal angioplasty, auto transplant, and arterial bypass surgery. And of course, it's important to consider this management. And this is just few studies that were done in South Africa showing that children with Takayasu arteritis can undergo surgical interventions successfully. Of course, there's still a risk of getting complications, particularly in the form of rupturing, particularly when you're trying to do angioplasty, because the vessels are quite friable. And it is usually advised to start immunosuppressants first before you attempt any surgical intervention for these patients. So these are just records from South Africa, which is showing what kind of surgeries have been tried and the immunosuppressions that were used. And I can see it's interesting that even total lymphoid irradiation was used as one of the immunosuppressions for treatment of Takayasu arteritis, which is quite interesting. But it's in the past. Now we have a lot of molecules that are better and easily tolerable. And it's also interesting to show that the surgical interventions have shown to have an impact in the functions of the kidney. So this is a study which was done in South Africa, showing a retrospective study showing that with revascularization there was an increase of the EGFR, showing that there's improvement in the renal function for these patients that underwent this condition. So the other challenge with Takayasu arteritis is the fact that there are no disease monitoring tools that have been validated for children. There are several disease activity scores that have been tried. One of them is pediatric vasculitis activity score. This has been validated in children. However, it was validated in 63 children and only 6 had Takayasu arteritis, making it not that useful. And these other tools are not really useful and they have not been tried to so there's one of these challenges. The commonly used criteria for monitoring Takayasu arteritis is the NIH tool, which was used in the NIH studies. And this is looking at the constitutional symptoms and presence of new bruits, elevated acute phase reactants, and any new angiographic findings. So basically, this marks the end of my talk, and I believe I've been able to show you that Takayasu arteritis is rare, but it is also rarely diagnosed in children because we rarely pick hypertension, and imaging play a huge role. And despite the fact that imaging play a huge role, we have a huge shortage of these imaging tools. I want to believe that in the block of East African countries, there are only 1 or 2 PET scans that is available at the moment, which makes it difficult to have access to this one. And the mainstay of treatment is steroids and steroid-sparing agents in the form of methotrexate, azathioprine, as well as MMF. And biologic therapy is something that is coming up, and we might be able to use it confidently in the near future with the availability of evidence. Thank you very much.
Thank you very much, Dr. Francis. In the interest of time, I'm going to now hand over to my co-chair to introduce the next speaker, and then we'll go into a few minutes of questions and discussion. Thank you very much for a great presentation.
Thank you very much for your presentation. Now we will follow the presentation of Dr. Tanatar from Istanbul University in the Department of Pediatric Rheumatology. She will present an oral abstract entitled Systemic Autoinflammatory Disease, This is a multi-center cohort study. Dr. Tanata, you have the floor.
Okay.
Hello, everyone. I'm Dr. Ayşe Tanatar. I'm a pediatric rheumatology fellow at Istanbul University, Istanbul Faculty of Medicine in Turkey. Thank you to the organization committee for the opportunity to presentation. I will present our study titled Systemic Autoinflammatory Disease, a multi-center cohort study. Systemic autoinflammatory disease are a group of hereditary disease characterized by inflammatory attacks accompanied by clinical findings such as fever, skin rash, abdominal pain, and musculoskeletal symptoms, and with high autophagic response. Familial Mediterranean fever is the most common monogenic autoinflammatory disease, mainly affecting populations originating from Mediterranean basin. In this study, we evaluate our patients with prototypical autoinflammatory disease other than FMF, mevalonate kinase deficiency, tumor necrosis factor alpha receptor associated periodic fever syndrome, and creatinine-associated periodic fever syndrome. The objective of this study sought to define the characteristic to report 24-month follow-up children with systemic autoinflammatory disease and to compare the performance of both the previously validated classification criteria Federici and new Eurofever Pirinto classification criteria in a multi-center cohort under real-life conditions. The medical chart of 60 patients diagnosed with systemic autoinflammatory disease who were followed up regularly every 3 months between 2010 and 2021 in 6 pediatric rheumatology centers in Turkey were retrospectively analyzed. Demographic data, clinical findings, laboratory results, and treatments were recorded. Next generation sequencing gene panel consisted of 16 genes associated with periodic fever syndromes was performed in all patients. Results, a total of 60 patients, 30 female with systemic autoinflammatory disease were evaluated. Among patients, 30 were diagnosed with MKD, 22 with CAPS, and 8 with TRAPS. The median age at disease onset was 22 months. The median age at diagnosis was 72 months. All patients were followed up with a median 31 months. The rate of consanguinity between parents was 35%. 35% of the patients had a family history of autoinflammatory disease in their first-degree relatives. The frequency of clinical symptoms was fever, 95%, arthritis 63.3%, gastrointestinal complaints 58.3%, urticarial rash 56.7%, myalgia 48.3%, lymphadenopathy 33.3% respectively, urticarial rash 86.4%, cold-induced rash 45.5%, and arthritis 50% were significantly higher in CAPS patients compared to other two groups. Lymphadenopathy 46.7% was more common in MKD patients. Clinical diagnostic and classification criteria were shown in tables. When we applied the diagnostic classification criteria to our cohort, 71.7% met the Federici criteria, 53.3% fulfilled the Eurofever Pirinto classification criteria. When the performance of two diagnostic criteria was compared, the proportion of patients fulfilling the Eurofever Pirinto criteria higher in TRAPS patients compared to other groups. A significant decrease were found in IDI score, CRP levels, ACR levels. From the first month in CAPS patients, in MKD patients, there was a significant decrease in IDI score and ACR levels from the first month. In TRAPS patients, there was a significant decrease in IDI scores from the first month of treatment. At the last visit, 93.3% of the patients were receiving anti-IL-1, 5% receiving were receiving anti-IL-6 and 1.7% were receiving colchicine. 90% of the patients were in complete remission. In conclusion, we showed that the diagnostic classification criteria may not always be sufficient to make the diagnosis, and there is still low agreement between clinical diagnosis and molecular analysis. Anti-IL-1 treatments have been found to be quite effective in the treatment from the early period. The evaluation of the genetic data, 60 patients as a result of a next generation sequencing panel are shown in table 1. Thank you for your attention.
Thank you very much. I think we're going to ask Dr. Dayabu Ibrahim now to manage the questions if there are any. I know there were one or two for Dr. Francis relating to the use of pulse steroids in Takayasu's arthritis. Dr. Francis?
Thank you, Professor Kala. I think that's an interesting question, and of course, it is something that people might be concerned whenever they are thinking of the possibility of having hypertension, malignant hypertension. But again, so the indication of pulse steroid is when you have a life-threatening Takayasu arthritis, manifestation of Takayasu arthritis, including severe cerebral ischemia, for example. If you're on the verge of losing the blood flow to the vital organs, so that's the time you use methylprednisolone, and this is used for a short time. And basically, at the time this drug is used, there should be a good monitoring, and this patient should be receiving other treatment for making sure that the blood pressure is well controlled. So I want to believe that you have to weigh the risk and the benefits, and it is usually given at a very difficult situation when you are at the verge of losing vital organs and or losing the patient. Thank you.
Prof. Kala, how are you?
Do you have a question? If not, then I think we'll call this session to a close, and we'll now go on to the second session, which will address several issues related to juvenile idiopathic arthritis, and it'll be chaired by Professor Scott and Dr. Solyom. Thank you very much for your interest and attention. Bye.
Thank you very much. So my name is Katie Crosby. I am a genetic counselor, and I'm here today in place of Dr. Solyom. So thank you all for being with us. My background is in rare genetic diseases, and we will be presenting a talk today about a rare genetic cause of juvenile arthritis called Farber disease. So I'm very pleased to introduce our two speakers today. First is Professor Chris Scott, who many of you know, who is the head of pediatric rheumatology at the Red Cross War Memorial Children's Hospital, and as you may have seen, the newly appointed director of the Clinical Research Center at the University of Cape Town. His research and educational focus is on the care of patients with rare and rheumatic diseases in Africa and less resourced communities, and has a special interest in access to care, and as many of you know, advocacy roles as well. I'll also introduce Professor Boris Hugel, who is a staff rheumatologist and the director of research at the Center for Pediatric and Adolescent Rheumatology at Garmisch-Partenkirchen, Germany. His area of expertise is on the diagnosis and treatment of rheumatological disorders in children and adolescents, and training other physicians in this regard. He's also served as a co-investigator of many clinical trials and serves as the reviewer of very high-tier rheumatology journals. So I'm very pleased to be here today. I'm from the company Acerigen. We are sponsoring this talk today. We are working on an investigational therapy for Farber disease, and I'm very happy to learn from the rheumatology community and to present these speakers. So with that, I'll pass it over to Professor Scott. Thank you.
Thanks very much, Katie. It's fantastic to be here, and I'm thrilled to be talking about another rare disease, which I'm sure has passed through my hands, unbeknownst to me in the past, and I think when you mentioned that we're all passionate about access to care really starts with a diagnosis, and there's no greater feeling of relief when a family have been looking for a diagnosis, haven't found one, and are left wondering what's going on. And there's also something for us as physicians that is terrifying, is the idea of giving therapy that doesn't work for a condition which has been misdiagnosed. So this is where my interest in this originates. Now, Farber disease diagnoses are being made all over the world. And there's a broad phenotypic spectrum that's emerging as people are finding patients, as with many conditions familiar to us in rheumatology, like with DADA, etc., DADA2 deficiency. The spectrum grows once people start recognizing the disease, and it's all about pattern recognition. 70%, though, of these children who have moderate and attenuated Farber disease are first diagnosed with JIA, which is to us as pediatric rheumatologists and rheumatologists is a frightening thought. So we will see these children, they will pass through our hands. I'm quietly confident some have passed through my hands before I heard about Farber disease. And here you can see the map of the areas in the world where Farber's is being diagnosed, and you can see why Aserajan has asked us to present this to this audience. There's a critical need to be able to identify these patients in other parts of the world. So as you know, this is not new to us as pediatric rheumatologists. Rare diseases are actually quite common when you put them all together. In fact, all of the things we look after are rare diseases, and yet we all seem to be very busy. It's more likely that a patient who has a variety of symptoms has one disease that's causing all of the symptoms rather than several different diseases appearing all together. A little bit opposite to what we're often taught in medical school, where it says that if you hear horses, if you hear hoofbeats, think of horses. And in this case, we want to show you how to look for the zebras that are making the hoofbeats. Pediatric rheumatologists, which is not difficult for African pediatric rheumatologists, I'm sure. Pediatric rheumatologists many times see difficult patients with complex symptoms, and we're used to this area of looking for different diseases that present as one syndrome. And joint diseases, as you know, are features of many rare genetic conditions. So we want to prompt you to look at your strange and atypical cases, especially when they don't respond to therapy, and consider this condition. And also bear in mind that genetic testing and genetic consults have changed the landscape for us. And in this case, Dr. Hugel will tell you more about these what can be done in the case of Farber's, and I'm really looking forward to his talk and to getting a better idea of the clinical spectrum and the feel of a patient with Farber disease, because I'm confident once we start making the diagnosis, we won't stop. Thank you, Dr. Hugel, and thanks so much for doing the rest of the talk. I'll advance your slides on this side, I'll just say, and there'll be a little lag in between when I click and when you see the slide changing. So, but I promise to stay awake.
All right, thank you, Katie, and thank you, Chris, for this very nice introduction, and thanks for the organizers for the chance of speaking here. I must admit, when Aserajan asked me to do an expert talk, I don't really feel like a Farber expert. I mean, we had 5 patients in total in our center. I've been treating 2 for, well, within the last 20 years. So that maybe makes me an expert, but this is a very rare disease. Can we have the next slide? Okay, so I must admit, I'm a bit of a methotrexate buff, so anything described by Sidney Farber is of interest to me. You know that Sidney Farber, who is called the father of modern chemotherapy, he worked on folic acid antagonists and amnopterin and methotrexate, so he is one of our rheumatology heroes. But on the side, in 1952, he also described this lipid disorder with a deficiency of the lysosomal enzyme ceramidase in 3 patients who all died in infancy back then. He also showed that this is an autosomal recessive inheritance pattern. And what he could already describe was that quite impressive accumulation of lipids. So what we call lipogranulomas, they're mostly in the joints, but they're also found on the vocal cords. And you can see the nodules here from the image from different patients, and they occur at any age and they do get worse over time. If you cut them open, you can see that there is a massive accumulation of ceramide, mostly chondroitin sulfate, which leads to inflammation, and that leads to a fairly typical picture of arthritis as inflammation, but it's in the vicinity. So next slide, please. Okay, that doesn't see, but you can see this image. This is pretty much what we can piece together, and it's a fairly straightforward genetic disease. So we do have mutations in the ASH1 gene on chromosome 8 with autosomal recessive inheritance pattern. So one allele is usually enough to give normal function. And then we have deficiency in the enzyme of the ceramidase, which means that the ceramides cannot be broken down. Of course, they accumulate, and that leads to the macrophages coming along and saying, well, we have to clean that up. And that leads to inflammation. And there is 2 diseases that are caused by that. Most of the cases are Farber disease, which is a whole spectrum of diseases that we'll talk about here. There is another more recently described phenotype that's called spinal muscular atrophy with progressive myoclonic epilepsy that I'm not going to go into here, but there's really only a handful of patients all in all. So at least from a pediatric rheumatology standpoint, you will probably not see this. And this is diagnosed in children and adults, but symptoms typically appear either in infancy or in early childhood. So next slide. That's a picture of a colleague of mine who is very fond of this imagery, basically Alex Simon, who's not here today. And he always thinks of Farber disease as a disease of trash removal. So basically the packaging, what you can think of as the cell membranes, which are made of ceramides, that's not broken down. They litter the street, and in this case, the body, and they create all sorts of problems and can cause all sorts of inflammation and annoyance. Next slide. So for Farber's disease, the older literature usually mentions the typical triad. So we do have joint symptoms, either joint contractures or arthritis or both. We also have subcutaneous nodules, the lipogranulomas, and very typical but often overlooked is the hoarse or weak voice because of the ceramide accumulation on the vocal cords. And that is indeed typically misdiagnosed as juvenile idiopathic arthritis. Seronegative rheumatoid arthritis is it must be pretty late, but usually we see these patients as JAA. And the nodules are more of a problem than you would actually expect. And patients do not really get better with anti-inflammatory treatments. Respiratory failure and CNS disease is only something that occurs in early cases, so which you would see if you see these patients in infancy, like within the first year of life. The moderate phenotypes present much more like a JAA. So next slide, please. There has been a natural history study done on Farber's disease where patients with the moderate phenotype were investigated. And you can actually see these nodules here on the images, and you can also see the contractures, which are another problem. So that actually occurs early on. It's one of the signs that distinguishes from JAA, because in JAA you do get contractures, but you do need a lot more information before the contracture happens. Here, you actually have the contractures first and then the nodules and maybe some inflammation, but it's not really in equilibrium. And what the natural history study showed was that the nodule sizes actually correlate with the impairment score. So the nodules cause day-to-day problem in these patients. Next slide, please. So, of course, when you have made the diagnosis of Farber's disease, you sit down with the parents and they ask you, what can we do? And the textbook answer, unfortunately, is pretty much nothing. Right now, there's no disease-specific therapies available. There have been some successes with stem cell therapy, but and we did have patients with a moderate phenotype who did quite well. However, this is not an option for patients with the early form. So the patients where you would really wish for a quick treatment, and if they have any neurological impairment, as the early forms frequently do, the results are very bad. So it's not an optimal treatment. The enzyme replacement therapy is under development, and we're really waiting for that to be developed. Other drug treatments, not so much. There is usually anti-rheumatic drugs don't really give you a benefit. There is a little bit of a discussion about tocilizumab. The interleukin-6 blockade seems to have some anti-inflammatory effect, but it certainly doesn't treat the disease sufficiently. Next slide, please. Okay, so the enzyme replacement works in theory, at least it has been shown in mice. You can see on the left side, the lower picture is mice with the ASAH1 mutation. So you can see on the of these three mice, the left is the wild type, in the middle is heterozygous, which is really very similar to the wild type, and to the right you can see the patient with ASAH1 homozygosity, so it's very small, stunted, and you can see in the pictures above that he has infiltration of macrophages, meaning that he has inflammation, and the synovium is hyperplastic and there is ceramide accumulation. So this is a quite useful model because the ASH1 gene in humans and in mice is very similar. And there has been work done by Asaragen actually using the human acid ceramidase, the enzyme replacement in mice, which you can do because it is actually quite similar. And you can see in the images to the right, left side is the wild type mouse, where you can see the bone marrow is normal, and untreated, you can see that there is fatty accumulation in the bone marrow. You can see that also on the magnification below. And then if you actually treat them with a ceramidase, then the bone marrow returns to normal. So that is quite encouraging. And so enzyme replacement therapy seems to be the way to go for these patients. Next slide, please. So there are several take-home messages, but this is the first take-home message, that Farber's disease is often misdiagnosed as JAA. The typical symptoms can take quite a long time to appear. They do not necessarily have to appear together. And you can fairly easily test for the disease with ASH1 genetic testing. And the arthritis doesn't really respond to anti-rheumatic treatments, including biologics. Yes, and ceramide accumulation in Farber's disease leads to macrophage-driven inflammation, which is very similar to other forms of arthritis, but the nodules are not. Next slide. So, you've heard about the triad that is always mentioned in the literature, and here we have to add a fourth symptom because it is actually quite helpful in the clinical setting. So you do have arthritis and you do have nodules and the hoarse voice, but you also have patients who are you show inadequate response to anti-rheumatic treatment, biologics here, but any other anti-rheumatic treatment as well. I mean, the patients will not react to steroids as well. There may be other symptoms, including pain and fever and failure to thrive. Osteolysis is something that occurs later. There's one interesting case that I'll show you later on. And of course, you have patients who have that in infancy, but you do have to distinguish like the CNS disease and the pulmonary involvement. That is usually the more severe cases that get that early on. I actually have a video which might or might not work of a patient with Farber syndrome, and you can see one thing is that you can see it's not on the and the other is very stiff by the contractures. Okay, that's but it's nice to have been seen a patient. Okay, so in general, we divide Farber's disease into three main categories. There is, in the literature, there's more subdivisions, but it really comes down to you have only very few patients in general. There's about 120 to 150 right now. So there is really no point in further subdivision. But in general, you can say there is the very severe phenotype, rapidly progressive, that shows an early onset. You have the moderately progressive, which we as pediatric rheumatologists should be most aware. And there is the slowly progressive attenuated phenotype, which is only a handful of patients really. They're interesting case reports, but we do see ASAH1 mutation in older patients who have a variety of symptoms. I'm going to talk about the different phenotypes now. So next slide, please. All right, so the early form occurs shortly after birth, and it has a very severe course. The patients have a CNS involvement, growth, mental retardation, quickly develop nodules. They usually have pulmonary involvement as well, and these patients are in severe pain from the inflammation. Usually die within the first years of life. And unfortunately, especially in these patients, stem cell transplantation practically never works. There's, so far as I know, no patient that has survived stem cell transplantation. But again, symptoms can vary, and they can appear in any order. So next slide. This is the patients that you will most probably see. They're, the moderate phenotype means that patients occur, they come within the first couple of years, they develop nodules that develop increasing joint symptoms, but the illness is not life-threatening. They can have CNS disease and mental retardation, but more often they don't. And these are the patients where you actually really have to be aware and think about. And the hoarse voice is frequently overlooked, but that is one very good that's one marker that really helps patients doctors to make the diagnosis. And as you can see here, more than 70% are diagnosed as JIA. How could they not? I mean, we as pediatric rheumatologists, we know that if you have arthritis, which is affecting several joints, it's most often JIA. It's very rarely something else. And nodules can occur with rheumatic diseases, especially if you treat with methotrexate. So, like I said, not really surprising. And next slide. There is attenuated cases of Farber's disease which grow into adulthood. There is these two sisters who have always been are always given as examples. There's a couple of other patients as well, and you can see there from the hands that they do have these nodules on the fingers with the arthritis. They also have short stature and mild contractures, but that has taken a very long time to make that diagnosis. But there is certainly misdiagnosed as JIA. And it just goes to show that it is worth to take the genetic testing at any age. Now, next slide. That's one very interesting case that has been described a couple of years ago of a patient who was 60 when he was diagnosed, and he had this odyssey of going to doctors, and his symptoms actually started at age 3, where he had these pain symptoms, and he had a little bit of nodules, and then he lived with his joint pain for pretty much his whole life. And in later life, so age 40 and over, his fingers and toes actually shortened, as you can see very impressively on these images. So he developed osteolysis rather than the subcutaneous nodules. And it turned out that he is positive for ASH1 mutation, but normal development, otherwise no neurologic problems. So this came as a surprise and just showed us that, yes, the spectrum of Farber's disease is very broad. Next slide, please. So these are it's worth repeating the key to the diagnosis at any age is joint contractures or arthritis, subcutaneous nodules, hoarse or weak voice, and refractory to, well, at least anti-rheumatic treatment or biologics. Next slide. So to finish up, I'm going to take the opportunity to tell you about one of my patients, Timon, who I've been treating within the last 2 decades. So at the start, he was a 2.5-year-old boy, non-consanguineous parents, and he started with contractures of the middle fingers, very similar to a Dupuytren's contracture, and he did have hoarseness, which was not really noticed very much at that time. But he had significant limitation of motion, he had thickening of the tender sheets, he had swelling of several large and small joints, ankles, wrists, elbows, significant pain, limitation of motion. He didn't really have any nodules at that time. They came later. But like I said, it's understandable that one would make the diagnosis of JAA at that time. Next slide, please. These are images from later on, but you can see his nodules on the fingers, which are almost grape-like in appearance. You can also see that he actually has a large effusion of his wrist, which never really went away. So he did have joint disease and nodules. Next slide, please. And ultrasound showed some effusions, no really synovial thickening, no really synovitis in the joint. He did have some synovitis in the tendon sheets. He had normal blood work, no really systemic inflammatory signs. So he got the diagnosis of JA, was treated with methotrexate, treated with methylprednisolone, which of course led to some improvement. It always does. It's kind of basically doping. And after 3 months, where nothing worked, then he was started on etanercept, which was fairly new at that time. And really no effect. And he had increasing nodules, he had hoarseness, he had these progressive contractures, and he was resistant to any inflammatory treatment. So this is just a more recent picture where you can see the contractures in his knees and his elbows. And again, these nodules happening especially on his fingers, also on his ankles and feet. Next slide, please.
Recording in progress.
So after half a year of treatment, we clued into the nodules and his hoarseness. Back at that time, the diagnosis was done by Thierry Levade in Toulouse, who did the fibroblast cultures. And later on, the genetics also showed the ASH1 mutation. And of course, there was nothing much that we could do for him except for intensive physiotherapy. We did try chloroquine, but before we made the diagnosis of Fabry's disease, we tried the etanercept again, which did help a little bit with the pain, but not much. The parents didn't really want to do the stem cell transplant. So basically we cared for him, did intensive physiotherapy for quite some time. There were some reports about tocilizumab from Sweden, which improved his outcome a little bit. You can see that he had slowing of contractures, but there were still new nodules appearing. So it had a modest effect. Next slide. So right now he's doing fairly well. He does have nodulosis, he does have the hoarseness, and he has ongoing symptoms, but he has no mental impairment. He's now able to do a desk job. Unfortunately, mom, as you can see here in the picture, got pregnant again, and he has a little sister who is also homozygous for ASAH1. And when I last saw her, at 3 or 4 years of age, she developed symptoms similar to Timon, very, very much alike. So next slide. Take-home messages. Just it bears repetition that arthritis and contractures, they can appear alone. The nodules can appear later in the disease and can lead you astray. The hoarseness is very early, usually. It's a very good marker, but of course it can be overlooked, especially if the kids don't talk to you. A neurological impairment can be missing or very, very mild. But contractures that progress really are not usual for rheumatic disease. So it's useful to do ASH1 testing in these patients. So next slide. I think I'm already out of time, so I'm just going to stress this again. Diagnostic testing is easy. ASH1 gene really only needs a dried blood spot card, and it is available in patients with joint disease who do not respond to biologics, especially if they have nodules. Next slide. Well, think genetic testing. Next slide. And Asaragen actually provides no cost ASH1 genetic testing, and that's the email that you can contact them. So like I said, if you see patients like that, go ahead, just send for the test. And we hope that the enzyme replacement treatment comes soon. All right, that concludes my presentation. Thank you for your attention. Do you have any questions?
Thank you very much, Boris. I'm not sure if the organizers are allowing us much time for questions, but I see there are some on the system, so I'll ask them, and if the organizers want me not to, they best let me know soon. The chat's just dropped away here. Where's it gone?
I can see someone is asking a comment on why there's preferential accumulation of ceramide in the joints. That's a good question. I mean, we do see that the ceramide accumulates in areas with soft tissue. So basically, we see it in the vocal cords, we see it in the joints, we also see it, for example, in the ear. So in the vicinity of cartilage, but really, I couldn't tell you why exactly that happens.
Thanks. I see I've got my chat up now. I see.
All the other questions are for other speakers.
For other speakers. I have just a quick, very simple clinical question. Maybe I'll ask just two of them. The nodules, what do they feel like? Are they fleshy? Are they firm? Are they?
They're hard. They're
very hard.
They're accumulation of the ceramide, which usually is very, very hard to the touch. Not as hard as rheumatoid nodules, I have to say, but I mean the rheumatoid nodules, they're these pearl-like things, but they're still pretty hard.
Right. Thank you. And the other question was just quickly, when the chap you showed, the young man you showed with arthritis or with the swollen wrists, when he went for ultrasound, they didn't see much fluid, but they also didn't see much synovial hypertrophy. But something must have been there to cause all of this swelling. So there was also no tenosynovitis. So what did they see?
The fluid came later. He didn't initially have a lot of fluid, but later on, if you put a ultrasound on the wrists, you would be.
Okay. So it eventually does cause synovial hypertrophy and fluid as the primary sign.
Yeah, but it's kind of, you wouldn't really expect. Or let's put it this way, you would expect more synovitis and fluid in someone who presents. Later on, you could see that the ceramide is really causing the inflammation and actually makes bony damage, and it's very nasty. So it takes time to develop that.
Brilliant.
The timing of the symptoms. So textbook-wise, yes, you do have arthritis, you do have synovitis, you do have fluid, you do have contractures, but the contractures you would expect in the end for JAA, and they appear in the beginning. So that gives you that little, that doesn't really fit feeling.
Interesting, yeah. I think I have a much better idea now of what to look for and how to look for it. Yes, and I can just comment, I've sent several blood samples via the dried blood spot, and I must say it works very well. It's very easy. The patients do it themselves.
Yeah.
It's very easy to do. Yeah.
It's still worth checking when you have the suspicion.
Yeah, absolutely. And there's lots to gain and very little to lose when the testing is for free.
Yes.
Well, thank you very much, Dr. Hugel, for a great talk. I don't think there are any more questions that I can see, and I don't see any hands up. I've been asked to ask you just to go out of this room and then rejoin the next talk from the lobby again. All of the attendees, all 77 of you who are here. All right. Thanks very much. Have a good evening. Bye-bye.